working right now.
Excellent. So we have a number of questions here. Before we get to that, I want to ask one general question of all of you. You all are currently using these tools, but right now they're primarily being used within a single discipline. And the general discussion that we've been having here for the last day and a half is making that move into an IPE environment. Talk just very briefly, and some of you have mentioned a couple of potential examples, but talk very briefly what you would envision this assessment tool to look like when it's assessing a team or a group of interprofessional students. How does that work? How do you move from a platform right now that is focused primarily on an individual and an individual discipline to a team and multiple disciplines? So we'll start on this side and we'll move on down.
Okay. Right now, the clinics that are actually using it, so the 100 clinics, are both physician and they are singular, so physician and dentistry. So those are the two disciplines that we have using it right now. We have a current pending, hopefully to be funded soon, research that we are looking at one of the bigger healthcare systems in Central Texas to look at their transitional care unit to those individuals that the hospital system has said do not, who are chronic, coming back into the hospital, regular readmissions. And this population is very transient, but they have 5 teams of healthcare professionals. They're nurse practitioner led, and those teams include a RD, they include dentistry, they include social work, and often a physician and or PA. So that nurse-led team, then equipped with an iPad and or mobile technology, the idea is then to be able to provide that information based on the complexity of the group of patients that is assigned to that team, to be able to assess the information and the connection of that content and delivery from the provider and or team of providers to the patient. We're hoping to do 2 outcome studies that would show exactly the engagement of the professionals as well as the engagement from the professionals to the patient, and what long-term then how the outcomes will be changed from a behavior standpoint from the patient. So not currently being done today, but that is something we know for sure is something we need to be doing, and hopefully start that in the next month or so.
Great. Barbara, you're on.
Well, as a guest here, I was very pleased to hear that one of the issues that was brought up is to bring some sort of policy, something to help us schools that don't have IPE abilities because we're not tied to a medical center. Maybe the clinical facilities don't have team steps or have an IPE program in place, that you are looking and seeing that we have these needs in our schools and addressing them. So it was wonderful. I will go back. We have a networking session of Illinois lab and simulation coordinators actually next week and say, you know, I went to this forum and they hear us. They say they're looking at ideas and solutions. So I look heavily to the literature. I look heavily to places that have adapted IPE and looking at their tools, trying to get into team steps, training, but using video and the existing IPE sources out there for our curriculum because we really don't have. So I did meet and network with a lot of people, and hopefully we can maybe find schools, people to work with to try to develop our own IPE maybe within the community as well, rather than the outpatient, inpatient.
So I want to preface this with the fact that we've learned a lot of lessons from K through 12 space, and Khan Academy is used right now in about 30,000 classrooms. So a lot of what I'm going to say is actually coming from that space. What we do is try to identify what content is best taught, what we think online, and what content is best taught in classrooms and in communities. When it comes to interprofessional skills, you're working in a team, you know, thinking about good communication, managerial skills, these are things that are probably best taught in person. And what we see as kind of a mistake is that classroom time is being filled with didactic information. And it becomes one way, it's passive, it's boring, frankly, and students don't go. And so we know class attendance is quite low. You know, medical school at least, it's around 10, 15%. And so a lot of empty seats. It just doesn't make sense. And so What we're trying to do is move all the didactic piece outside, and that's where I mentioned the fact that you can have online interprofessional collaborative learning taking place, especially in community forums. But in the classroom, I think what we have to do is start saying, okay, now let's get a team together and let's do a simulation, or let's do a role play, or let's take folks even out of the classroom into the community and actually see how they do in community settings and assess those skills with other humans around. And so I think that's the piece that people sometimes think, oh, well, let's just teach diversity online. And one of the problems with that is that I don't think it's the best form factor. Oftentimes it comes across as cheesy, it's PowerPoint, it's an inauthentic or kind of lame-looking role play. And so people just get turned off by that right away. And so how do we, I'm not saying that we can't do pieces of that online, but I haven't seen excellent examples of that online. And so I think a lot of that will have to be done in person. And I think that the pieces that we do online have to be carefully thought through so that they are engaging. But a lot of that, I think, should be moved into the classroom. And that's where we're trying to kind of get back a lot of that classroom time.
So are you trying to untechnology this?
Yeah, in many ways. I mean, we get approached all the time about these things because people think, this is important and we want to figure out how to do this online. And I think they're right, it's important, but I don't know that online is the best solution for every answer. I mean, I think there is a reflex to kind of jam everything into a round hole. But I think we have to recognize that online tools like Khan Academy are probably best suited for certain types of content and not everything.
Okay, before we get to the questions that I've got on the screen, would anyone here, does anyone here have a question? Yes, sir. Yeah, you have to use the microphone.
Rishi, I'm very excited about your work into the medical information domain. Do you have a profile and characteristic of who are your users now, lay versus professional, and at what level of professional development they are? Tell us a little more about that.
So I'll speak to the Khan Academy medicine users. That's probably the piece you're most interested in. So we have so it's only been live. I mean, Khan Academy has only been alive for about 3.5 years. Khan Academy medicine has only been alive for about 1 year. In that year, it's been viewed by about 2 million folks and used by about 2 million folks. Those people are generally between the ages of 25 and 45. The content that gets most used by patients, and this is just based on essentially focus groups and some comments that you can kind of read into, the content that gets most used is the really shallow stuff, is the welcome to understand this, what is that, really basic understanding of pathophysiology or what is that disease. And I think those are primarily patients that are using those bits of content. The stuff where people go deep, it's almost all nursing and medical students that are going deep, and that's international. And that gets into pressure volume loops, EKGs, things like that. And it's primarily healthcare students. One surprise is that you actually find out that once you put content out there, it's not always the expected user that will use it. And we've had 13, 14-year-olds actually responding and asking very deep questions on pressure volume loops or afterload. And so you don't always know who's going to use this content, which brings up the point that I think if explained well, a lot of these concepts are not out of the realm of any kind of interested, curious individual.
Yes, sir.
I'd be interested in your perspectives on how gaming might evolve in health professions education.
Well, I think it's the upcoming generation is all about gaming. And I think we need to start embrace gaming by playing their games, trying to get on Xbox. I tried to get on Second Life. I have an avatar stuck on an island and I can't figure out how to get out. But definitely we need more because the young students, so the 17-year-olds coming in, they are motivated through gaming, through Snapchatting, texting, interactive games on his website. Actually, Dr. Desai, I was setting up a simulation. It was going to be acute respiratory distress syndrome, and I needed to learn about ventilator settings. And believe it or not, I went on Khan Academy, found ventilator settings, and Dr. Desai really did a great job. In 10 minutes, ventilator settings. So definitely what's going on in Khan Academy and online.
What are the differences between what the Khan Society is providing, whatever it's the organization, and Coursera? There are so many fabulous Coursera courses now coming from some top universities. And is there a plan to integrate and coordinate?
So there are a lot of MOOCs, massive open online courses. When I was a medical student at UCSF, we had essentially the same thing where people would videotape the lecture, we could go home and watch it. One thing I want to say is that on the plus side, obviously we are opening the doors to higher ed, and a lot of people have access, and that's a huge advantage. On the minus side, that was available 12 years ago when I was a medical student, and none of us watched it because a bad in-person experience is still a bad online experience if you just put it online. So just putting something online isn't the answer, obviously, but increasing the quality of teaching and education is what matters. And so one of the things, a year and a half ago, I had to decide where to go, and I gave a lot of thought to this. When we think about the course, it fundamentally is what we have been using because that's what worked for a long time. I'm not sure it's the best answer going into the next generation for a few reasons. One is that, I took a course, let's say in biostatistics, when I was at the CDC. Do I know today what I used to know 2 years ago? Probably not, because I haven't practiced it. And so there is something to be said for continuing your education and actually having a real-time demonstration of that, insofar as I should be, if I'm going to say I'm certified in biostats, I ought to have some demonstration of that. I should be able to do a task, to have an ongoing requirement that says these are questions I have to answer. Those are the kind of things that you would ideally want. So in our model, we don't have a start in March and a finish in June. If you have a profile with Khan Academy, you'd have a learning dashboard, and parts of that kind of get filled in. But if you want to maintain that, you have to maintain that. You have to keep answering questions, keep going back, refreshing yourself. If things change, we can take information down, put new information up. It's a live system. It's not a static system, which is fundamentally different. And it requires that we create content, which is for us a big challenge. How do you create quality content? And we're increasingly thinking of our users as not just content consumers, but content producers. And so with games, we actually get a lot of our games from our users. They will make a game for us explaining what will happen if the myelin sheath is gone. You won't get an action potential. Why is that? Why will it go faster? They'll create games around this. And so it's an incredibly instructive activity to have young folks making games around medicine and health because it teaches them, and it also teaches the community about this content. So that's essentially what we're tapping into, is this rich community, world community of content producers that can make games, and they can help us, with videos. We have these national competitions for videos now, to bring that in and not simply say it's the Stanford professor. I can say that because I'm working there. That is the know-all and end-all just because he's in the front of the classroom. We all know that the smartest person in the classroom is probably your iPhone. So the idea that I'm going to stand here and talk to you doesn't really make sense. We can look things up now. And so that's another thing, is that we're starting to introduce a peer review system, which again, a lot of courses don't do that. Just because I say something is true, the ventricle, that we have 3 ventricles in our heart, that's not accurate. And yet because I said it and it was captured on video, that might get out there. But that's not true. And so the idea of a peer review system in our content, I think, is a huge step forward in quality as well. So those are some of the differences between the MOOCs, yeah.
I'm really going to be bad and ask you what it will take to get all 3 of you to move to Toronto.
No way.
I'm really frightened by the fact that, even as you said, and I really mean this with great respect, that learning, even in this context, there are 8 of us tweeting, by the way, and I've tweeted your photograph. No, actually, I did hers. But the idea being that knowledge dissemination and knowledge sharing is still based on a very traditional setting in higher education. And it's so, again, like the healthcare system, it's so complex in that the funding formulas, certainly where we are in Canada, are based on the number of widgets that you pass through the factory. And I find that so annoying. And I guess my question is twofold. One is, how do you get past that patronizing mentality that's deeply embedded in health care in that patients don't need to know. And I still run into that, right? Whereas what you've described is that, in fact, everyone could have every bit of information. How they cope with it is a different issue. But I can see the avatar as being very helpful to, patients of mine who have borderline personality disorder, and they can get stuck on the island. But also the ones who are challenging through the knowledge that they just can't assimilate in the 2-minute wrap up from their oncologist. So how do you get past that patronizing barrier? And the bigger issue is how do you get past the institutional barrier, where we are as simulation is a whole bunch of, high-tech interventional rooms, half of them underbooked. So I know these are big questions, but can we possibly find that partnership with Nextbox or Xbox that can actually get us into that realm to break those barriers? Because I can't convince people who don't use technology that it's actually the thing to do.
I would say from my perspective, there's many studies that say, 80% of patients are coming to their provider with already, identifying what's going on with them, their ailments. And likewise, providers are frustrated by the fact that the content of the information that they're actually coming to them with is invalid and inaccurate. So I think the challenge for what this technology that we're presenting, wouldn't it be nice if you could be the person that actually gives the content as the provider to the patient that you want them to know and understand and digest and be able to actually make improvements of their own health? I think what's interesting is it does put the question back on the provider. Do you want to have that kind of connection with all of your patients? And do you want to have that direct access and them to have that direct access to you? So in the case of this technology, it's bidirectional. So I, as a provider, send you the information. I'm going to be able to know whether you took part of that information and read it, and how many times you read it, and how many times you opened and viewed that video. And you can ask me questions if you want me to, back to you as a provider. But it extends that visit that is institutionalized, as far as what you're getting reimbursed for that patient visit. So there's complexities in opening somewhat of Pandora's box, right, of patient engagement. But I would say it's probably necessary.
Yes, I was wondering in the context, Margaret, of the app that you were talking about. We have so many apps right now that we can look at our own lifestyle management, which is badly needed, and so we really have our health in our own hand. And again, that's another technology that we're really not leveraging to not only facilitate patient engagement but also accountability. So we don't have as many non-compliant folks because we don't really give them some of the tools that they need. So the technology you're talking about, is it connecting at all to some of the ways for people to track either their blood sugar or other kinds of things for chronic care management, or just for lifestyle management? Or is this just about engaging back with the provider, which still creates that uneven relationship rather than shifting it? I'm just wondering if that's being developed. This is for stage one to moving to where we really would be able to tell the difference that it's making, rather than just, are we connecting?
Absolutely. So today, it's available. So the beauty of it is that it can be done by you as the practitioner, exactly what information that you want to use. Or we have been placing information that, from a nurse practitioner lens, has been touted as, yes, this is good, viable information. This is what I would pass along to my colleagues. So from the foundation's perspective, we've made some of that available, but can be used or not be used by that individual practitioner and or healthcare system. So to answer your question more directly, it's really up to the provider on the type of measurement of that chronic disease, comorbidity, whatever it is that you are trying to push through your patient population, or as a team that you're trying to get through and be able to measure for a long period of time. So when you start measuring it, that sets that benchmark, right, to, what is your ROI, and what are the things that you're trying to measure as a clinic and as a healthcare system.
And is that downloadable into some form of a platform, whether it be connected to a PHR or whatever, so that we begin to shift the management and the tracking and the monitoring of health and wellness?
I would say yes, everything is interfaceable. in that regard. So there are systems that it can connect to. Ideally, it is really to start that conversation and that measurement with the patient upon engagement.
Hi, our discussion about the emerging technologies, and thank you about the apps, simulations, the Khan Academy and all that, reminds me of decades ago when we went to the online learning, distance education. There was a lot of naysayers, well, they're still there today, where how can you possibly learn online? We have to teach face-to-face and the lecture it comes from their mouth. Now we have all kinds of evidence where learners do learn, and there's best practices and what goes online versus doesn't and all that. So we're coming to that with all these emerging technologies, and we need to change. And it brings me to the point with MOOCs. Should we be putting some of this IPE core content, core IPE simulations, core materials in a MOOC format where it is worldwide, it's free, we're disseminating it everywhere? And what are those? I go back to those IPE competencies again. What's the content we all need? So then we can have application in our own institutions. I'll give you a brief example. At Johns Hopkins, we're doing MOOCs in nursing. We just put the one on dementia care. It affects everybody. It affects caregivers. It affects health professionals. The news release went to New York Times. Now there's 17,000 in the MOOC, and it's not even started yet. But with that said, I could try to teach dementia care, which is not my background, but if I did, in decades of teaching with 50, 100 students, I could never get to 17,000. So look at the population we're reaching and the impact. So I challenge us, should we be doing something in IPE education and through the emerging technologies in a massive online open course?
That would definitely address the needs that we have in our academic institutions that are not tied or have limited capabilities for doing IPE. That would really address that solution, and love massive online open community education. I actually attended one and was very fascinated by it. But we need to see what our students are coming in with. Our 17-year-olds are so smart with their technology, and integrating that technology in the classroom right away is so very important in order to keep them engaged. And so definitely to address the other question, how do we break the barriers? Our students are bringing this technology with them in clinical, and the other staff is seeing that they're able to look up these things very quickly. They're able to show patient videos that are evidence-based and peer-reviewed, and they're like, oh my gosh, where'd you do that? How'd you do that? Can I use your phone for a second? And so they are transforming, these students are transforming our healthcare system and breaking those barriers.
Question for Margaret about your app. A couple questions, actually. Could you talk a little bit about why your foundation decided to do this, how they came about deciding on the exact way it's been developed, and then what the business model is for its rollout and its use? Is there costs to patients, or clinics, and other, et cetera, to use, and how it's related? Was it driven from the nurse practitioner profession, or was it broader goal when it was developed?
Sure. The reason why we engaged is one, as I mentioned, our big program is our scholarship and research grant area. And we had been looking for ways to really, when you test the definition of innovation, what's that next marker? So we were introduced to Leading Reach. Any of you know Austin, Texas very well? We have become kind of a mecca of technology. And so we have been interfacing with a lot of different really great innovative ideas. And this organization came to us and said, look at this platform, look at what we're doing. And so for us, it seemed to take education and information from a provider to a patient to the next level because it made it viral. So that is kind of the short answer as into why we're interested. And the business model for us is that like I said, it's already being used with physicians and a couple of healthcare systems and dentists. So we are kind of representing the lens of the nurse practitioner and pushing that through the beginning of nursing, and particularly in nurse-led clinics. For the business model for us is to just make it available. Try something that is going to help you and then tell us how that's working. So we, in August, mid-August, we announced that we wanted to make it available to 250 nurse practitioners for free to really start to build that capacity and understanding of how it's working, to really test that scoring mechanism of patient engagement. We recognize it's Pandora's box, like I said, of defining patient engagement, but to put it out there and make an attempt to really help that score and that information and that challenge of where we're moving from a healthcare system and a healthcare solutions. How do we make this happen, and how can we have an actual number that associates with the practice of education and information transferring from the provider to the patient? So for us, we wanted to make the technology available, and then to look at pilot sites and specifically look at chronic diseases. How's it helping? Somebody mentioned the example of diabetes. And that's more than a 9-month study, right? So to really make sure that care has been taken through the continuum of that disease path with that patient and that provider. So we are at the beginning stage, and right now the business model is to make it available and put in pilot sites so that we can actually research and understand how it's really helping, and then turn that information back and explain how it is working. Yeah.
Is the vision then that a clinical system would use this app and make it available to the patients that are part of that system to engage?
Yes, so you don't, as a patient.
To the patient.
Yes, so as a patient, you don't have to have the app or the technology. It's just through your email. So I see your question. It's just through your email system that you're receiving, and there is like a 7-page HIPAA document that our partner is following, and so we're covered in that regard. But that information transfer is meant to be the crux of, can you measure that information given actually to behavior change? Can you make those correlation between the behavior theory model and the practice of what's given from the patient to the provider into practice?
Just one last point, kind of picking up on what Pam was saying, and that is for us to really not only think about how it is that we teach, but what it is that we teach, because I don't know as much about it as I'd like to, but I know in California they're really looking at a new health catalyst model in terms of the education. And so when you link the access to technology at the patient engagement and family engagement level, then you teach differently. So we aren't always, in that expert role and pushing information and pushing advice and then calling them non-compliant because they don't do it. That we really change and reshape it, but we have to reshape how we think about the roles that we teach in addition to the content within the roles.
I have a couple sort of quick stories, and then it leads to a question to all of you. So how many of you remember when you were 16 years old, or within a week of 16 years old, how many of you ran to the nearest DMV to get your temporary driver's license? Most of you? Do you know that number of 16-year-olds who are driving has dropped precipitously? Do you know why? They don't need it. They don't need it. Are they less connected than we were? No. Another quick story. When my house was very popular when my daughter was 14 years old, or 14, 15 years old, because we had 4 computers in our house, all connected to the internet. So 3 of her friends would come over, and what would they do? They would all go into separate rooms. Why? So they could talk to each other. Because, yes, they could talk to each other if they were in the same room, but then they couldn't talk to all their friends. So, it took me a long time to sort of sort through that out. They would all come over, and then they would spread out, and they wouldn't see each other the entire afternoon. They were all on the computers, but they were all connected, and they were all talking to their friends. So there's a lot of connectivity that is going on. In the current practice environment, though, when we think of IPE or interprofessional care, a lot of what is going on is not the different professions in the same room. So I have a lot of primary care docs in a particular neighborhood who, when I asked them, could not tell me the name of the 2 pharmacists in the area. And yet 90% of their prescriptions were going to these pharmacies, and the pharmacists knew more about their patients than they did. They'd never, and at least one of these guys had never seen the pharmacist, wouldn't have known him if he tripped over him. And yet there was, there was the opportunity. In fact, there was a certain amount of interprofessional care going on, but they really didn't know each other. So more and more, when we think about interprofessional care, it's not, it's not all the professions in the same room. There's a lot of team skills being learned online by people that don't know each other. So they're games being played by teams of people that have been on the same team for years in different parts of the world or different parts of the country, all working on the same team. They become very good, tight, close team, integrated friends, and they had never seen each other. They probably will never see each other. So when we typically think of team-based education, immediately we think of how can we get the pharmacy students, the nursing students, the medical students, the social work students all in the same room. So if any of you are from academic health centers, you know that that just doesn't happen. Not very easily. They're in different places. They've got different schedules. It's really, one of our biggest challenges is actually this physical presence. So you folks are all in the technology area. How do we adapt the technologies that you're talking about, that you're using, to develop team-based skills without folks ever seeing each other? Or is that an absolute requirement for you?
So I'll describe how our team works at Khan Academy, and I think there's some lessons to be learned. Certainly we didn't work like this at the CDC. So at Khan Academy, we use a tool called HipChat, and HipChat in Silicon Valley is fairly well known. And essentially, it's a tool where you can create kind of windows, and my team working on analytics is in one group. Separately, tab over, I've got my team working on content in another room. My online dashboard team is the third. And I can immediately start getting pinged back and forth. We're all in the same physical room, but it's silent. And we're just all working away, chatting with 6 different teams at once. To take your example, I can imagine a patient being part of that too. You can imagine getting, and on Khan Academy, actually, I've used it this way, where I have a patient with TB or latent TB infection on INH who is my student. I'm their coach on Khan Academy. They go and consume videos. They're the same videos that a medical student, nursing student might watch. They come back and they say, I noticed my LFTs went up, because they looked that up. I noticed based on your video that it doesn't meet the threshold for stopping INH. I'm guessing we're going to have to recheck them. You're like, yep, that's about right. That's what we're going to do. And these are 14, 15-year-old students that are just, they get it. This makes sense to them. And so this dichotomy we have in the content realm between UpToDate / PubMed on one side, WebMD / Google on the other side, I think can be bridged. We can create a place where people on both sides go for just good information. That is the foundation. Then you have something like HipChat kind of overlaid on that and create a team that the patient or student kind of identifies and says, look, this is my pharmacist, you're my doctor, you're my this, you're my that. And especially for complicated patients that have lots of members on that team, I could definitely imagine a scenario where we communicate through a chat room, essentially, and say, look, this is what, he just came in, do you mind giving the suspension? So that, yeah, I can do it. So I could imagine a scenario like that very easily. HIP.
I envision, one of the roles in simulation could also be observer. An observer learns during simulation by observing, and I envision that maybe Johns Hopkins, as they're doing an IPE simulation, allows other schools at that time, either through Skyping, either through Google Meets, any kind of open platform software, to allow us to observe, to allow us to look, to listen to the debriefing, and then come in and we can all chat together and learn together. And that's how I envision using technology and sharing resources, innovation and practice.
I think the technology that we're suggesting or we're implementing allows the team to be able to actually put a measurement and an understanding to the content that's being provided by every person on the team, and be able to talk to each other, but make it mobile. So I don't have to be connected to a terminal in the clinic or in the department. I can actually give an iPad to every member of my team. The RD has it, the social worker has it, the nurse practitioner has it, and then we can go out and do home care. We can do care within the large hospital system, and then be able to connect by one point within that technology, that I can see everything that's been done, because the back end of that data shows the result of how we've connected and worked as a team, as well as how we've hopefully influenced patient care and treatment at the same time, based on what has been sent to the patient and the dialogue back and forth. So I think it's be a perfect student application to be able to use this, even though it's meant right now and being used in clinical and hospital situations. But I could see a very nice simulation, if you will, and with students to be able to measure that directly.
Any other questions before we get to the questions? Yes?
This is my area I'm passionate about. I think it's important, though, to keep in mind what you were saying, Rashia, in terms of it's both and, it's not either or. When I was dean at Colorado, I didn't know what they're doing now, but we would bring students together just to share differences in roles and then focus on ethics and leadership and areas of common content. But it was just the beginning, and then they continued their communication and links with each other. So it wasn't like we had to bring them back in body every time. But if they met, in the hallway, that was great. But I think it is a combination of where we do have people together and they can develop relationships, then extend that relationship. So I just want us not to fall into the either or trap that so many times we do.
Yes, sure.
So this is question related to the care we provide. I think we know that in this country we have disparities, and there is a very powerful report that came from IOM on literacy and lack of literacy in this country. So I just, as we move more and more into the technology and providing care, are we creating also more disparities in terms of technology disparities, but it's also language disparities, and the have will have more and will have more access, and the have-nots will have less access because we are moving in that direction. I just want to hear your thoughts on that, because I'm really getting very concerned. There are a very large population who are not going to be able to access any of these things, and what's going to happen to them.
I have a few statistics right now just on that. We do know that there's about 80% of U.S. households that have internet access, and we do know that about 78% of the U.S. consumers are interested in mobile technology. And even though that there may not be a large, there's still a disparate population with that, it does continue to grow in interest and in actually obtaining it. I think we have to be clever about, even though it's provided, that it's not maybe the only way that you provide care, that you provide information. I think there's still, if its availability is and it's viable, but it may not necessarily fit every population in every community situation. And I think we have to be able to say that comfortably out loud.
Along the same note, two things that we've done to try to address this, and I've seen it in practice, is that we actually are trying to figure out ways to get the hardware available in clinics, so that when you're in the waiting room, I mean, just kind of think of optimal situations. When you're in the waiting room waiting for an hour for your appointment, you can actually use that time. If you're in the ER, also in kind of a point where you're interested in your health, you can use that time. All of our content is translated, and so it's available in Spanish, Farsi, Arabic, and that's actually quite useful, because I know a lot of physicians and NPs and RNs will go into a situation where they don't understand or speak the same language, and they have to make a judgment call. Do I call the interpreter and wait 30 minutes or 20 minutes or however long it takes? Or do I just kind of flub my way through? And a lot of people do the latter, or if it's not available, they'll just kind of do their best. And having the content available in another language is useful, also because it's not like my patient's parents are always there. Sometimes it's their abuela that comes with them, and that message about asthma needs to go back to dad or to mom. And so knowing that they can actually access it later is useful because then that message doesn't get messed up along the way because of the telephone game. So,
You just need to be conscious of this all
Oh,
the
yeah.
time in whatever it is we are doing. Thank
sure.
you.
Yes.
I just wanted to make a comment about the disparity. I know with the MOOCs, whether it's Coursera, Khan, or whatever, what's being created too are smaller learning communities in different areas. We also have a MOOC on tuberculosis. It's going to cross 135 countries. And what happens? Somebody in India, they'll go to the restaurant and 30 people are around talking about the content that's coming up every week or whatever. I can see patient-centeredness going that way as well. So you're building these smaller communities from the larger communities. So people are figuring it out. And I do understand, though, not everybody has the technology or the bandwidth that's needed, but that's exploding as well.
I have two thoughts. One is the resource intensivity that you mentioned in terms of maintenance and learning and, in fact, creating the platform, which I think is something we should really think about in terms of one of the pieces that we want to take forward, because I believe that we need to actually decide that we're changing the contract with the learner, patient, teacher contract has to change. And that means that some of the things we talked about is how to engage the patient voice in the assessment. We had actually mentioned that in the waiting room, there could be a way to actually establish those expectations. And at the end of the encounter, to have some kind of mechanism so that automatically, whenever I order on Amazon, I automatically get a pop-up. And since that technology is already there, how can we harness it to move forward? So, I mean, that's a very important piece. And it really goes to, I guess, wondering whether you think that we could come out of this with a new mechanism of continuing our conversation as well. Because 150 people like me can't take up all the time talking. But is there a mechanism, I know it's resource intensive, but is there a mechanism for us not to have to schedule in a big meeting, but we're actually also doing hip chat, which I think would be something that we could use in this dialogue to take our recommendations or our consensus thinking forward.
I primarily learned simulation back, 2006 with Dr. Jeffries, following her closely. And I turn extensively to communities or listservs to learn and to gather information. And I think one of the key players that we need to have on board, even in this forum, is the technology people that are developing these products and saying, this is what we need. They need to be at these meetings. They need to be part of our forums as well, the people that do develop and harness all this. Rishi's, I think, a really good pioneer, but having those really Xbox. Let's bring Xbox, because we know kids will play Xbox, and it's our upcoming generation.
I was going to say that our partner, they actually started in the trade show mobile touchscreen technology. And so in about 2012, they broadcasted this technology in 75 different countries. And so because of that exposure and what they were doing, somebody said, why don't you do something in healthcare? So that's kind of why this got started. And again, going back to when you asked me the question about our interest, I think that's a fabulous question. Why not in healthcare and really get started there? So yes, having technology partners at the table and part of the conversation, I think, is key.
10 or 15 years from now, I suspect that the health systems who are taking care of populations will simply give out the technology because it's going to be so cheap. And they'll even train their patients if the patients do not have the ability to immediately pick it up, which is getting less and less likely. They'll wire the patients home, or it won't be wired anymore, but they'll put some communication device. We're already doing that with telemetry. So it's pretty clear that where this is going. So I think the issue of disparities, which is a critical issue at the moment because we don't have a confluent system where everyone has access to these tools, is going to disappear simply as part of the ongoing business plan. And it says, so my question to you is, to what degree, what priority, what emphasis do you have on, do you put in your various ideas to gaining health system buy-in to this at an earlier rather than a later stage, because the funding of this, the business case for this is obvious. And the health system that can reduce readmissions or can manage a particular condition better, particularly in the bundled payments that we're dealing with now and with accountable care organizations, is going to be able to use this kind of technology. So to what degree have you really pressed your case with those kind of folks?
So the way that we see our value is that we have a really great platform and that we're building our content. One of the biggest pushbacks we get from folks that want to use our content is they'll say, well, it's not complete. You know, I can direct my folks on diabetes to you, but I can't really direct my arthritis patients. So what we're trying to do is create a complete package, mostly complete. And then our thought is really the next step would be implementation. And so implementation partners could be anywhere from Kaiser to Blue Cross Blue Shield to Stanford University academic centers to a rural clinic in Uganda. And so we're starting pilot projects in these places to kind of understand what are best practices, how is it being utilized, what are some assumptions that we had made that are incorrect, things like that, to try to figure out, does it work in a low bandwidth setting truly work? Does it work in a place that's an academic, busy place with an EMR that's different than this other EMR? And so we're starting those relationships now. Our thrust has definitely been around getting the content ready.
From an academic standpoint, we have made a serious saying that the students have to have some sort of smart technology coming into the classroom. Whether we decide to withhold a textbook that could cause a comparable value, but saying that this is the most important thing, that we can start out as an institution in academia to say that students have to start out with this technology. Because yes, we have the young learners, but then we have the 50-year-olds, the 45-year-olds that are coming in for a second career. They need to learn this technology. So we've integrated it and made it a requirement that every student has. We don't identify which technology, but that has the ability to utilize technology from the very beginning of their program so that they can bring it on into the institutional level. So we're starting at the academic and very heavily requiring them to have the technology.
Yeah, my back's to you, but so I was educated in an area of certainty where people knew exactly what they were telling you and how to do it and so forth. And I think over and over again I'm hearing we're now really in an area where we have to have a very high tolerance for ambiguity. And ambiguity in how we deliver care and think about care, and ambiguity in education. The certainties are really, maybe the content's a certainty, but everything else it is not. And the other thing I think is what's really interesting, that certainty means that the 1,000 or million or 10 million points of light often have been suppressed in the past. And because there's not going to be the same amount of certainties, certainly because of technology and other things, we really have to embrace the ambiguity and embrace an environment where we encourage over and over again in many, many forums the importance of what people like yourselves are doing and many others in the room. So again, in my head, most meetings like this come up with a series of recommendations. So we substitute one certainty for another probable certainty that we evolved in so many days, and I think it's just the opposite now. We have to encourage evolution, millions of points of light, and a very high tolerance and acceptance and embracing ambiguity. I'd be curious what you all.
I think that's true. I think that's pretty much how I answered that last question about about disparities and so forth, because you have to at some point try something, and based on good sound knowledge and information, of course, but notwithstanding, you do need to start somewhere and be able to have the courage to go ahead and put into practice what you know to be certain, and watch what happens as you follow through.
There are two quotes that hang at Khan Academy. One is "make something people want," and then there's another quote that is "shipping beats perfection." And the second one kind of alludes to your point, which is that we we really pride ourselves on getting products out and iterating on them. I think in many places where I've trained, there's this forced notion that we have to be perfect as we walk out, and that's just kind of a fallacy, because we don't even know what's perfect until we put something out there and kind of iterate and see what it is that consumers want, and that's ever changing. So our product has to be ever changing as well.
I have a question for you all. In some of the discussions here, one of the themes that's coming through is that information is more universally available. It's harder and harder to segment the information so that only certain people can get it. So yes, you can get a 13, 14, 15-year-old getting on websites and getting information, other people. We have, from time to time in the last day, talked about caregivers, patients, other people as part of the healthcare team. There are potentially many more members of a healthcare team. It could be teachers, it could be daycare workers, it could be coaches, it could be any number of folks that are in a situation where having this knowledge and being able to communicate could actually enhance health or healthcare in some way. What does your technology do for the ability or desire to have a healthcare team that could be much expanded, or secondarily could be very fluid at any one time?
I think our technology, because it's can be used on a multitude of different ways, laptop, it can be a mobile device and so forth, it makes it somewhat easy, should you have that technology available to you, to be able to use it in a variety of areas, like you mentioned, the daycare worker, the variety of care individuals. And I think that if there is a way to connect that team with specific outcomes and objectives, I mean, that makes that much more purposeful, right? It makes it much more understood how its impact is really verified. So I think for this technology in particular that we're working with, it's well suited for a variety of professionals.
I think my technology in terms of collecting synchronous data at the time of simulation or knowledge acquisition ultimately impacts patient safety, because when we can identify students did not get this content, they were not reacting to the low oxygen or the respiratory issue, correct the problem. Then when they go to clinical, oh, Professor Gravern, guess what? I had a patient and her pulse ox was 88 and I knew what to do. That is the most rewarding thing that an educator, so that technology, having instant synchronous results of your learning objectives to help you understand where the learning gaps occur in education or pre-licensure.
So this is not available today, but one thing that I think would be really powerful is if you have, let's say, a problem like anxiety. We know that anxiety or depression probably not best handled, I think, in a very static way where I see someone every 6 months. That doesn't really make a lot of sense to me. I can imagine that you might have a person identify who they think would be the right people to be on their team to help them overcome this issue of anxiety. Maybe never overcome it, but at least cope with it more effectively. And say, look, the people are going to be my mom, my husband, my physician, and my best friend. And these 4 folks are going to hold me accountable to these things. And these things are going to be, I'm going to meditate, I'm going to do yoga 2 times a week, go running every morning, and eat more salads. These are the things that I'm going to do to help overcome my anxiety. And I can imagine going to a place where you can identify your coaches and say, these are the people I think are going to help me get over this. And I think that's a step in the right direction. And it's the patient identifying and being the driver then of the car. And the driver is no longer the MD or whoever society tells us should be the driver, but it's the person that's most vested in the best outcome.
I'm afraid I'm going to have to cut off the questions just so we can stay on time. I want to thank the panelists for their presentations and their thoughtful answers. Thank you for your questions. And Eric has some comments to make, and then you actually will be able to get up out of your seats.
Yeah. That was fantastic. Thank you very much. Just a quick housekeeping thing. We're going to take a break until 11:10. If you need a cab, please let Megan or the staff know as soon as you can so they can get those arranged for you. We'll see you back at 11:10, and we're going to come up with some next steps, stuff we can actually do. See you then.